Welcome back to Prescribing Hope, Azithromycin Unmasked. I'm Rittika, your host with a master's in neuroscience, eager to unravel the science behind azithromycin's role in the COVID-19 era. In today's episode, we are going to look at the pharmacokinetics, deep dive, absorption, distribution, and lung tissue penetration. We're exploring how this drug moves through the body to reach its battlegrounds. Saakshi returns today, a pharmacological cartographer charting the wind road azithromycin travels through the body, from the gut to the lungs. She maps this drug's epic tissue quest like a saga through cellular terrain.
Thanks, Rittika. I'm excited to dive into azithromycin's pharmacokinetic journey. It's like mapping a traveler's path through the body's complex terrain.
Let's start with the first leg of the journey, absorption. Can you detail how azithromycin is absorbed after oral administration? What factors influence its bioavailability and how it compares to other macrolides like erythromycin and clarithromycin?
Absolutely, Ritika. Azithromycin taken orally as tablets or suspension has a bioavailability of about 37%, meaning roughly a third of the dose reaches systemic circulation. This is moderate compared to clarithromycin's 50 to 55%, but higher than erythromycin's 25 to 35%, which is less acid stable. Azithromycin's 15-membered azylide ring with its nitrogen insertion enhances acid stability, allowing it to withstand the stomach's pH better than erythromycin, which degrades rapidly. After ingestion, it's absorbed primarily in the small intestine with the peak plasma concentration or Cmax of nearly 0.4 to 0.6 microgram per milliliter, reached in 2 to 3 hours for a 500 milligram of dose. Food slightly reduces absorption by about 20% if taken with a high-fat meal. So, it's often dosed on an empty stomach. Its bioavailability is limited by first-pass metabolism in the liver, where cytochrome P450 enzyme or CYP3A4 play a minor role, and by its high affinity for tissues which pulls it out of plasma quickly. Unlike erythromycin, azithromycin's lower hepatic metabolism reduces drug-to-drug interaction or drug-drug interaction, making it safer for patients on multiple medications. This balance of stability and absorption sets the stage for its extensive distribution, which is where it really shines.
Sakshi, you have traced azithromycin's absorption like a river, carving a steady path through the gut. Its azylide ring, a sturdy vessel navigating the acidic waters. Unlike erythromycin's fragile raft, it reaches the bloodstream with finesse, ready to explore the body's vast landscape. You mentioned distribution as its true strength. Can you dive into how azithromycin distributes into the tissues, particularly its volume of distribution and the role of phagocytes, and why this makes it stand out amongst the other antibiotics?
Okay, so before I start, what is this 31 to 33 L per kg means?
Liters.
So I just have to say liters.
Yeah.
Azithromycin's distribution is indeed its superpower, Ritika. It has an exceptionally high volume of distribution, around 31 to 33 liters, compared to clarithromycin's 10 liter or amoxicillin's 0.3 liters, indicating it disperses widely beyond plasma into tissues. Its lipophilic nature and basic chemical structure allows it to cross cell membrane easily, accumulating in acidic compartments like lysosomes. A key player in this process is phagocyte, neutrophils, and macrophages as well, which actively uptake azithromycin, achieving intracellular concentration 40 to 100 times higher than plasma. These phagocytes act like our courier services, transporting azithromycin to infection or inflammation sites where it's released in response to bacterial signals or even tissue damage. This results in tissue concentrations, especially in the lungs, tonsils, and urogenital tract, 10 to 200 times higher than plasma, with the levels of 1 to 10 microgram in tissues versus 0.01 to 0.1 milligram, in tissues versus 0.01 to zero point 0.1 microgram per milliliter in blood. This tissue tropism is critical for infections like pneumonia or chlamydia, where pathogens hide in deep tissues or cells. Compared to erythromycin, which has poorer tissue penetration, or clarithromycin, which achieves lower intracellular level, azithromycin's phagocyte-driven distribution makes it uniquely effective for both extracellular and intracellular pathogens, hence enhancing its clinical versatility.
Saakshi, you've painted azithromycin as a nomadic warrior, carried by phagocytes, stitched to the conquered distant tissue realms. Its vast distribution a sprawling empire dwarfing other antibiotics. This tissue homing prowess feels like a beacon lighting up infection's darkest corner. You hinted at its long tissue half life. Can you explain how this prolonged presence shapes azithromycin's dosing regimes and what specific advantage does it offer for treatment compliance and efficacy?
Azithromycin's tissue half-life is remarkable, ranging from 2 to 4 days in tissues like the lungs and up to 7 days in some compartments, compared to clarithromycin's 5 to 7 hours or erythromycin's 1 to 2 hours. This stems from its slow release from lysosomes and tight binding to tissue components like phospholipids. In plasma, its half-life is nearly 68 hours, but tissues maintain therapeutic level above the minimum inhibitory concentration for susceptible pathogens for 5 to 10 days after a single 500 milligram dose or a 5-day course. Example, Z-Pack, 500 milligram day 1 and 250 milligram from second day to the 5th day. This allows once daily dosing and short course regimen, 3 or 5 days versus 7 to 14 days for many antibiotics, improving patient compliance, especially in outpatient setting. For example, a single 1 gram dose treats chlamydia trachomatis effectively due to sustained urogenital tissue levels. The prolonged presence enhances efficacy against slow-growing or intracellular pathogens like Mycoplasma pneumonia or Legionella pneumophila. However, it's a double-edged sword. The prolonged exposure can select for resistant strains like Streptococcus pneumonia, resistance rates from 20 to 40% in some regions, requiring judicious use. This pharmacokinetic profile makes azithromycin a cornerstone for respiratory, skin, and sexually transmitted infections, balancing convenience with potency.
Saakshi, you've cast azithromycin as a lingering guest. Its tissue half-life like a campfire glowing long after the feast, warming treatment plans with short patient-friendly doses. Yet resistance lurks with embers threatening to flare. Lung penetration was crucial in COVID-19 context. Can you detail how azithromycin's pulmonary pharmacokinetics makes it a candidate for COVID-19 and how tissue presence tied to both infection control and immunomodulation?
In COVID-19, the lungs are ground zero, with viral pneumonia and secondary bacterial infections driving severe outcomes. Azithromycin's pulmonary pharmacokinetics made it a compelling candidate. It achieves lung tissue concentration of 1 to 8 microgram, alveolar macrophage levels up to 80 microgram per ml, and bronchial epithelial levels 10 to 20 times plasma for surpassing erythromycin or clarithromycin. These levels, sustained for days post-dose, are ideal for tackling are ideal for tackling bacterial co-infections like Streptococcus pneumonia or Haemophilus influenza, which complicate 10 to 20% of severe COVID-19 cases. Beyond infection control, its high macrophage concentration supported its immunomodulatory role. Azithromycin reduces IL-6 and IL-8 in lung tissue, potentially mitigating COVID-19 cytokine storm, as we discussed last lecture. Its presence in alveolar macrophages and epithelial cells position it to modulate local inflammation directly at the site of SARS-CoV-2 damage. Early 2020 hypothesis, backed by small studies, suggested this dual action, antibacterial and anti-inflammatory, could reduce hospitalization or ventilation needs. However, trials like Recovery showed no mortality benefit, likely due to late administration or even limited antiviral impact, hence highlighting that lung penetration alone wasn't enough. Still, its pulmonary pharmacokinetics underscored its theoretical promise in addressing COVID-19's complex pathology.
Saakshi, you framed azithromycin as a sentinel stationed in the lung's fortress. Its high concentration, a shield against bacterial invaders, and a balm for infections fire. Yet COVID-19's complexity proved a tougher siege than anticipated. Thank you, Saakshi, for mapping azithromycin's pharmacokinetic odyssey. I'm Rittika, and this is Prescribing Hope, Azithromycin Unmasked. Stay curious.